Hello, my name is Josh Levitsky, and I'm a transplant hepatologist at Northwestern University in Chicago, Illinois. And today I'm presenting a video abstract of our recently published paper in gastroenterology entitled Risk for Immune-Mediated Graft Dysfunction Among Liver Transplant Recipients with Recurrent Hepatitis C Infection Treated with Pegylated Interferon. Just to give a little bit of background, as an immune stimulant, PEG interferon can cause or exacerbate both hepatic and extrahepatic autoimmune disease prior to liver transplantation. Similarly, PEG interferon may induce immunological graft dysfunction during the treatment of recurrent hepatitis C after liver transplantation. And this can manifest histologically as acute cellular rejection, chronic rejection, or immune-mediated or plasma cell hepatitis while patients are being treated with PEG interferon. However, little is known on the incidence, risk factors, and outcomes of PEG immunological graft dysfunction, or otherwise known as IGD. So our aims were to determine the incidence of PEG IGD among PEG-treated patients after liver transplantation, to determine clinical, biochemical, and histological risk factors for the development of PEG IGD, and to compare outcomes of PEG IGD cases compared to PEG-treated controls who did not develop IGD while on therapy. This was a multi-center case control study of liver transplant recipients with recurrent hepatitis C who developed PEG IGD, or the cases, versus controls without PEG IGD. We used 2 controls per 1 case, and we also calculated the incidence of PEG IGD cases over all treated patients at all of the centers. We collected clinical, biochemical, and histological data from each center's medical records. Pre-treatment, diagnostic, and follow-up biopsy slides were reviewed by a single-blinded pathologist. The overall incidence of PEG IGD in the study time period was 7.2%. This was divided into acute rejection at 3.2%, chronic rejection at 1.9%, and immune-mediated or plasma cell hepatitis at 2.1%. Risk factors, by comparing cases and controls for IGD while on PEG therapy, included the absence of pre-liver transplant interferon, the current use of PEG interferon alpha 2A, and importantly, immune features that were present on pre-PEG interferon treatment biopsy. So the biopsy that led the provider to treat the hepatitis C, if immune features were present, this was a significant risk factor for the development of IGD while on therapy. Importantly, patients who developed PEG IGD had significantly worse patient and graft survival and higher retransplantation rates. This was seen numerically and also on Kaplan-Meier analysis over time that patient survival and graft survival was significantly worse with the cases versus the controls. In addition, even patients who had a sustained virologic response on therapy had worse graft survival if they developed immune-mediated graft dysfunction. And finally, we looked at outcomes by each etiology and found that there was no difference between those who had acute rejection, chronic rejection, or immune-mediated hepatitis on therapy. However, we did look at variables associated with increased mortality, and this did include acute graft rejection, a high-level alkaline phosphatase at the time of PEG interferon initiation, and a lack of sustained virological response. These were all associated with poor outcomes in these PEG IGD cases. In conclusion, PEG IGD is not rare. It has an incidence of 7.2% in PEG-treated patients post-liver transplant and is associated with poor patient and graft survival, particularly if there is no sustained virologic response. However, even with sustained virologic response, there is an increased risk of graft failure. The risk factors for PEG IGD include being naive to PEG interferon, the use of PEG alpha 2A, and immune features on pre-PEG treatment biopsy. So it's important to carefully look at the histology prior to initiating PEG interferon for any atypical or immune features, and consider consulting other pathologists to help review these indeterminate cases, to maintain immunosuppression prior to and during interferon therapy, and evaluate abnormal liver function tests while on therapy so that this diagnosis can be made to improve the outcomes of these patients. Prospective trials investigating whether immune graft dysfunction, graft failure, and death in this patient population can be avoided by assessing immunological risks clinically and histologically prior to hepatitis C therapy post-liver transplant are of great interest and need. Thank you for your time and attention.